oncologist in the Center for Oncopathology at Tata Trust, Mumbai. Today, Singh from Uttarakhand Medical College, Srinagar, Dr. Tejas Vaidya from Pediatrics. Please leave the meeting. Thursday, we have this today.
We're interacting during this night seminar because it's not very easy to be interacting over here because we're relatively exposed. All the rest who are sitting behind the scenes are learning a lot from the interaction that goes on between the speaker and the students. And also I say that when one makes a mistake, not just the student learns who has made the mistake, but everybody else who is witness to this. So I thank all of you for having agreed, volunteered to come and interact with it. I think you can see my screen?
Yes, ma'am. Yes,
what is it that they need to do during this talk? Because I'm going to talk, and everybody is going to listen. That is without a doubt. So what are they going to do? Well, I believe that lecturing, that teaching is one thing, but learning is another. And as I said to them yesterday, learning is a very, very active exercise. Right? You do not learn if you only wish to be passively taught. So that's what they're going to do, and we're going to ask a lot of questions which will test the understanding of whatever we're going to talk about, the concepts in particular. Okay, so I'll just start with this. And the first thing is, I'm sure that all of you over here, the students here and those who are there know at least have had some understanding of what is neoplasia. And I just put down some of these facts that people believe are facts about neoplasia. It's there in all the textbooks, and it is taught by a lot of teachers, and also when you're a senior resident or whatever, you teach your junior residents, you teach second MBBS students, and we know that the definition of a neoplasm is what is put up over here, and it's the standard definition of what a neoplasm is. And I'll just read it out. It is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissues. And the things that I believe that are to be stressed and are stressed in all definitions are these that are I have depicted in red. Abnormal mass of tissue. It is growth. Growth is a very important part of this, and by growth we mean that there are a whole lot of cells, and that growth exceeds and is uncoordinated with that of normal tissues. And even more interestingly, most of our definitions talk about this mass of tissue persisting in the same excessive manner after the cessation of the stimuli which evoked the change. Now, if there is anyone amongst you students over here, who says that they haven't heard this definition, then please let me know. Okay. Otherwise, what we understand about neoplasia is this definition. Then we know that, at least we believe, that a neoplasm arises from the clonal expansion of a single neoplastic cell. So we talk about one cell and all its progeny that expand by division, otherwise you cannot get growth. And you will get a progeny of all of this single neoplastic cell, which then form the neoplasm. Right? And then there are different kinds of, at least two kinds of neoplasm. There are benign neoplasms, and there is cancer. And cancer is believed, that's how we define it, is that it is a malignant neoplasm. There are many kinds of benign neoplasms, and there are many kinds of cancer, but it is not my. See, once again, there's somebody who's asked for an annotation request, and I'm going to decline it. Arshad and whoever else, who's going to be here, I think by mistake you touched the top of the screen where there is a little squiggle. The moment that you touch that, I get a request for an annotation. Okay, so please be a little careful about touching that little thing that looks like a small snake or a worm. It's on the top right-hand side corner of your screen. So please don't do that, because it disturbs me, it disturbs everybody else. Okay, so cancer is a malignant neoplasm. Okay? We also are told, and it's there in most textbooks that you read, that cancer is a multi-gene disorder caused by somatic mutations. Yes, and then if you open some of the, better textbooks, it says there that cancer is defined by hallmarks, and I'm sure all of you know that. And the students who are here interacting with us, I think they went and did a quick read of the chapter on neoplasia, because that's what I told them to do. And I hope they've done it. And then there are, we all believe, and as pathologists, we have to believe this, that there are consistent differences between normal cells and cancer cells. Otherwise, what are we doing in pathology, right? You might ask yourself, if there are no differences, or the differences are not consistent, then how would we be able to tell a normal cell from a cancer cell? Okay, so we, all of this common understanding of neoplasia, and the last point is more or less the same as the previous one, and that is a cancer cell is definable. It is definable by and of itself. Now, this is the common understanding of neoplasia. So let us go through all of this and see, is this actually what we come across in our everyday pathology? And is there a need to add or subtract something from this common understanding of neoplasia? All right, so now let's start with the definition. And this is the definition of a neoplasm. I just read it out to you, okay? And then it says, I just added a little bit from Robbins, and that is fundamental to the origin of all neoplasms are heritable changes. That means one cell, when it divides, it gives rise to two cells, and those two cells inherit what the original cell had. So if there was something abnormal in the genome, its progeny will inherit it. That allow, and there you see excessive again, and unregulated proliferation that is independent of physiologic regulatory stimuli. So let me ask again, is everybody happy with this definition, or does somebody disagree? All right, let me start now with the A's. Okay, Anis?
Yes, ma'am.
You're happy with this definition?
Yes, ma'am.
All right. So now let me go through all 9 of you. Let me see if there's anybody who disagrees. Okay. Aishwarya?
Yes, ma'am, I agree with it, ma'am.
Oh, you do? Anvesha?
Ma'am,
Okay. So now let's ask Sikandar. You agree?
Yes, ma'am.
You do? There was a little, yes, ma'am. So is there anything that you don't agree with?
Ma'am, I recall that it's now they are researching about the polyclonal thing. That it's not monoclonal.
Polyclonal. Achha. So all neoplasms are not necessarily, come from one cell. Is that what you are
Yes.
referring to?
Yes.
Sikandar, I think that's a good observation, and we will discuss that. Okay. So what about Ashrita?
I agree, ma'am, but the heritable changes,
heritable changes?
It could be acquired also.
Oh, sure, but this heredity is not from your getting it from your father or your mother. This is one cell to the next cell. Okay, everything. How does the liver become the liver, etc.? Okay,
By
because it's inheriting, no, the changes from the stem cell, which then gives rise to daughter cells, and then they do it. So that's the heritable changes that they are talking about. Okay? So once you have got a cancer cell, its progeny will inherit all the changes that have made that into a cancer cell. Now, do you have any issues, Ashrita? Yes or no?
No, ma'am.
Oh, okay. So, Tejas,
I'm having some. No, ma'am. Not only the heritable changes, some changes like lifestyle changes. In today's world, there are many stressors in life, and there are researches going on there which says that some stressors also leads to cancer.
this is not about that. No, we just talked about it. It is what Ashrita asked before. It is not about what you inherit from your parents or whatever. Once a cancer cell has been formed, its progeny, the whole clone will inherit what this cancer cell actually starts out with. Do you have any problem with that, Tejas?
No, ma'am.
No, ma'am. Okay. Ujjwal?
Ma'am, I don't completely agree with that.
Alright, so tell me what you don't agree with.
Because I feel, ma'am, the definition doesn't cover the hallmarks, just partly covering the hallmarks of cancer.
Cover the hallmarks. You know,
Part-
you must. No, I'll tell you. See, if you have to define anything, you cannot say everything about it, right? Once you have a neoplasm, and if that neoplasm is a cancer, because the hallmarks do not apply to benign lesions. Do you realize that, Ujjwal?
Yes,
It
ma'am.
cannot apply to benign lesions. Okay, so the hallmarks have to apply to malignant neoplasms. Okay, and you cannot put everything into a definition. It has to be something that you say in one or two lines, normally one line, that means one sentence, which defines the thing that you're trying to define, and then you can expand on that definition and say that if, for instance, you're defining a human being, then you will say a human being has this narrow sort of definition, and then you will say, oh, there are human beings that have curly hair and those that have blue eyes and those. Now, you cannot possibly have all of that in the definition, no? So you have a lean, mean definition. Now that I've said that, Ujjwal, do you agree with this definition?
Yes,
Is there anything else you don't agree with? What? Ujjwal, I can see you.
ma'am, I agree with that.
Oh, now you agree. Good, Tej.
And
You agree?
this abnormal mass or tissue that is occurring in this type of
So
cellular
you
organism.
disagree with the abnormal mass. Is that what you're saying?
No, ma'am, it is okay, but it is occurring in this type of organisms or
In organisms. Meaning what? Sorry. Now it is an abnormal mass of tissue, and it is not just an abnormal mass of tissue. Of course, you have abnormal masses of tissue in all sorts of things. No, an abnormal mass of tissue may be granulation tissue. All right, but then they've added the other parts, the growth of which exceeds, is uncoordinated, that persists. So you can't disagree with the abnormal mass of tissue. Okay, that has to be there. Otherwise, how would you even know that there was a neoplasm? Okay, if there was no mass to actually identify. All right. So Gurtej, I think the rest of it you agree with. All right. Has Sumitra answered? I'm not sure. Sumitra?
Noted, ma'am. I agree with the definition, ma'am.
Okay. You agree with this definition. All right. All of you have more or less agreed with the definition. Now let me ask. All right. All of you have seen a uterine leiomyoma?
Yes.
Every one of you? All right. Very good. Now, is a uterine leiomyoma a neoplasm according to this definition? Let's start again. Anis.
Yes, ma'am.
Is it according to this definition a neoplasm?
Ma'am, yes, ma'am.
You think so? Anybody disagrees with Anis?
Ma'am, under hormonal influence, the size of the neoplasm does change, but it persists even after hormonal cessation.
I see. So what happens to a leiomyoma after menopause?
It decreased.
It persist in the same excessive manner after the cessation of the stimuli which evoke the change? Yeah? Anybody knows how we treat a breast cancer with hormonal therapy and what happens?
Yes,
Hormonal
ma'am.
therapy is used for debulking, like
Oh, does it? Is that so? Does anybody know? Ujjwal, you are in Tata Hospital, right?
Yes, ma'am.
Yeah. So if you remove the estrogen from the system by doing many things, you can remove the estrogen from the system by doing an oophorectomy. You can remove estrogen from the system by giving anti-estrogens. Yes, Ujjwal?
Yes, ma'am.
What happens to estrogen-dependent tumors? What's the point of giving it? They shrink, right? And they sometimes disappear completely. So now you tell me, never mind about breast cancer, we're just talking about a uterine leiomyoma. Okay, yes, it is an abnormal mass of tissue. And the growth was excessive and it was uncoordinated, otherwise you wouldn't be able to see it as a leiomyoma, all right? It wasn't forming normal uterine muscle. It does resemble uterine muscle, the cells do, but you can still see that it's a tumor and therefore it is uncoordinated with the growth of its neighboring uterine muscle. But there is no excessive and unregulated proliferation and it is certainly not independent of physiologic regulatory stimuli because leiomyomas shrink with the physiological stimuli that it undergoes, and we know that gynecologists actually tell patients with the leiomyoma, if they are somewhere around menopause, then don't bother about this. Okay, the leiomyoma will more or less disappear after you have become menopausal, and this is something that we know. So does this leiomyoma actually fit the definition of a neoplasm? And then you will say, this is the exception to the rule. And it is not the exception to the rule. You know that it is even a cancer undergoes disappears under physiological removal of the stimuli. Yes. And there you said it persists in the same excessive manner. It does not after the cessation of the stimuli. You remove estrogen from the system, and here we have Rini M. Rini M, again, you have pressed that. If you want to ask a question, then please don't ask for annotation, or you're doing this by mistake by pressing that little thing which I said you should not do. Okay, I'm going to decline this. Okay, fine. So obviously there are parts of this definition that do not apply to a majority of benign tumors. Yeah, even fibroadenomas shrink. Fibroadenomas actually become hyalinized and some of them actually disappear. Okay, so you get certainly to all many benign neoplasms. Okay. Is there anything else that we need to worry about? Now I'll ask you. Okay. Tell me this. What about an extra thumb? Would Is an extra thumb a neoplasm? Gurtej, you're there, right?
Yes, ma'am.
So is it a neoplasm? Go one by one. Is it an abnormal mass of tissue? Is it abnormal? Is it a mass of tissue and is it abnormal, Gurtej? Because you said something about abnormal mass of tissue. That's why I'm asking. Gurtej, is it an abnormal mass of tissue? An extra thumb?
And it should not be there, but
It's there, right? There you are. Did its growth exceed? Was it uncoordinated with the rest of the thumbs and the fingers and all? Yes or no? Just like a leiomyoma, right? It was uncoordinated with its normal uterine muscle. So was it supposed to be there and it's not there and it's there, right?
yes.
Edge? Very good. Did it persist, the thumb?
Yes, ma'am.
Oh yes, it did. Okay. After the cessation of the stimuli which evoked the change. So now tell me, why this is not a neoplasm, Gurtej? Why isn't it a neoplasm? Problem, no, Gurtej?
Yes.
Yes.
May I take
Yes. Yeah, who's that?
Anvesha, ma'am?
Come on, Anvesha.
Ma'am, there is no unregulated proliferation post the formation of that thumb. It is just persistent. It doesn't grow beyond.
Then the same reason you didn't give the same pass to the uterine leiomyoma.
But ma'am, leiomyoma may grow if there are estrogen.
It may not. You cannot decide, no, for the leiomyoma, Anvesha.
Yes, ma'am.
So you gave a pass to the uterine leiomyoma, but you're not willing to give that same pass to the extra thumb. All right, come on, let's start from the beginning. Anis, why is an extra thumb not a neoplasm? And I think we have to understand this. Then, all this hallmarks and this and that. Come on, why is an extra thumb not a neoplasm?
The clonality, maybe.
Clonality, so it's not clonal. Gurtej, Anis, are you clonal? Of course you are.
Yes, ma'am.
Every single cell in your body has the same genome as every other cell. And you're telling me that every cell in that extra thumb does not have the same genome? Huh?
It has.
It has. What?
Then the proliferation that happens,
So
consider
it did proliferate, otherwise you couldn't get an extra thumb, no?
But then the uterine leiomyoma can transform into a...
Oh, I see, and an extra thumb cannot. You mean you cannot get a cancer in an extra thumb, huh? This is wonderful. All right, Ujjwal, you're at Tata Hospital. Tell me why an extra thumb is not a neoplasm. Somebody will have to be able to look or think. Yes, Ujjwal.
Ma'am,
Come on, where are you?
ma'am, Tejas, can I speak?
Oh, Tejas. Yes, of course, Tejas. Yes, he's passed his MD.
Ma'am, I don't know whether I'm right or not, but I will try. The extra thumb which is there in any patient, in any person, it's normal to him.
It's normal to him. So then, why don't I say that so many people have got leiomyomas? A fibroid is a very common thing, so it's normal to those people, no? In fact, extra thumbs are much rarer than all the leiomyomas and the fibroadenomas, etc. Hey, come on, you guys. Can you not see the difference?
Ma'am, embryonic developmental anomaly? Like, it happens
Developmental anomaly. So now, who was that, Anvesha?
Yes, ma'am.
Anvesha. So what happens if you get, congenital neuroblastoma? What do you want to call it?
Neoplasm.
Why? It was there, no? The child was born with it. So now don't bring embryology into this story, okay? And the answer is very simple, no? When I like a thumb?
No.
No, it doesn't look like a thumb. The thumb doesn't look like a
Normal thumb. Normal. Like
Well, it looks like a thumb, no? Doesn't it have skin on the outside? It has a nail. Then it has the subcutaneous tissue. Then it has muscles inside. Does it or does it not look like a thumb? Yes or no?
yes.
Yes, ma'am. All right, very good. In other words, it is organized exactly like a normal thumb, which a leiomyoma is not. It is not organized like normal uterine muscle. Yes or no? Yes, so when I see a thumb and an extra thumb, I have good tissue organization. Now that is not reflected in this definition, okay? And that is something that we should think about. People talk about excessive growth and it goes on in an unregulated way and it is independent of physiologic regulatory stimuli, but we do not really think about something very important, and that is tissue organization. This is lost in all neoplasia, however benign that neoplasm is. And sometimes people say, oh, but what about a hamartoma? But let me tell you that a hamartoma is just another kind of benign neoplasm. Okay, there are all kinds of definitions of hamartomas, but for all practical purposes, it is actually another kind, and people who have bothered to test have also found that hamartomas are clonal. Okay, so I think let us at least accept that this definition of a neoplasm, please, you learn it by heart. If you're asked in the exam, please say this, but in your mind you have to understand that it does not cover everything that may be seen in neoplasia and not just exceptions to the rule, because every definition might have an exception to the rule, but here this is not this definition does not even obey the rule and its own rule. All right, so yes, we agree that there is uncoordinated proliferation, okay, which is also present in an extra thumb, but what the extra thumb does not have is disordered tissue organization. And however benign a neoplasm is, including a lipoma, you are able to see that it is a lipoma because it has not organized itself like normal adipose tissue. Okay, so there's disordered tissue organization. I say that it is often clonal. Yeah, and you know what clonality is. It's a process that affects one type of cell and which can be traced to one progenitor cell. And see, I have used the word often over here because, like somebody said, and I can't remember who it was, I think perhaps it was Sikandar, were you the guy who said that, no, I don't know, whether or Tejas, I can't remember who, but you said that things could be not always clonal, they could be polyclonal. I think it was Sikandar who said that there is research saying that things may have more than one clone. Very good, Sikandar. So, yes, the majority of neoplasms have just one type of cell, and all of the clone can be traced back to one progenitor cell. Now, having said this, I'm going to ask somebody, since it is clonal, yeah, Sumita?
Yes, ma'am.
Yeah, can you answer this question? Can an amoeba get a neoplasm?
Yes, ma'am.
Right, so Sumita says that an amoeba can get a neoplasm. Anybody disagrees with Sumita? Sumita, is your name
Will occur in
Sumita?
multiple organisms.
Sumita.
Sumita. Yeah, who disagrees with Sumita?
And it will occur in multiple organisms.
Yeah, somebody was answering. I know that Anvesha wants to answer, but I heard a male voice. Who is disagreeing? Yes, Ujjwal or Gurtej? Are very good, Gurtej. Tell me, why do you disagree with Sumita?
It will occur in multicellular organisms.
It will occur. What will occur in multicellular organisms?
Neoplasm.
Neoplasm. Why can't we get it in an amoeba? Will you please explain that to Sumita? After all, this is a clonal process, no? So why does it occur in? Do you think, Gurtej, that it can only occur in multicellular organisms? Explain to Sumita. You say that it occurs. Yes, of course, neoplasia occurs in multicellular organisms. You and I are multicellular organisms, and we have neoplasia. Rats have neoplasia, yes, and there are plants that have a neoplasia. Yeah, they're all multicellular. But can an amoeba get?
Amoeba is unicellular.
Organized, it will occur where organized tissue is formed.
That is absolutely right. If you don't have tissue, you cannot get neoplasm. And Gurtej, you're absolutely right. Because if one amoeba splits and becomes two, it doesn't stay together, right? What happens? There are two amoebae. So even if one amoeba has a mutation, then its daughter cells will have the mutation. They will become two amoebae. They cannot form a neoplasm, because a neoplasm means that there is a growth, and a growth of cells. And we have already said here that that growth, yes, is uncoordinated. It is often clonal, that's true, but that has disordered tissue organization, and no amoeba has tissue. Yes, Sumita, did you understand that?
Yes, ma'am.
You know that a unicellular organism does not have tissue. Okay?
Okay,
So it can only happen in a multicellular organism, and that too the higher orders of multicellular organisms, yeah, that form tissues. Now, if I have a sponge, for instance, okay, a sponge is a multicellular organism, but it doesn't form tissue. Okay, it doesn't have blood vessels. It's just a mass of cells that stick together. So it's an extremely unlikely situation that in some multicellular organism without tissue organization, that you will get a neoplasm. Now, are there any questions in the chat box about this before I go on to the next thing? Shrutika or Sindhura, is there anything in the chat
Ma'am,
box?
there are no specific questions, but the answers to the questions you've been asking to students on similar
One. Sure. There's one. Can developmental anomaly be compared to neoplasm?
No, of course not. Developmental anomalies, they are developmental anomalies, but they are organized like tissue, so an extra lobe, okay, in the thyroid. Remnants of things that had happened in the past. That means if you have, say, mesonephric remnants at one time, they were fully differentiated. Yes, you recognize them. That are differentiated for that particular stage of embryologic life. So it cannot be considered to be a neoplasm. I think we dealt with that when we dealt with the extra hump. All right, good. So if I had to define a neoplasm, how do I define it? It's an abnormal, often clonal, cellular proliferation that exhibits uncoordinated growth and disorderly differentiation, because that is what tissue organization is all about in a multicellular organism. Do people feel that this is worth considering as a yes? So all I'm doing is giving you a definition. Tejas doesn't have to remember this, or he may remember it, because he's already passed. There's no examiner who's going to ask him to define a neoplasm. But the rest of you still have to know what a neoplasm is. And for God's sake, don't give this definition, because your examiner who has not thought about it will probably not accept this definition. I'm giving it to you so that you understand what neoplasia is. Okay? So now that I've said this, who wants to take this question? What is differentiation? Because we say this all the time. This is well differentiated, poorly differentiation. This has lost its differentiation. So, who would like to take this question? Ashrita? Everybody's asking, but Ashrita hasn't spoken for a long time.
Yes, ma'am.
Ashrita, what is differentiation?
That the cell can functionally develop into that thing.
It is what? Cell?
Cell can functionally able to produce that thing. We can identify the cell like
Use that thing. All right. Some people wanted to answer. Who was that? Anvesha.
Aishwarya.
Aishwarya. Yes, Aishwarya. Come on.
How close the neoplastic cell resembles to the parent normal cell.
All right. That is how you say it is well, moderately, or poorly differentiated. But what is differentiation? Yes. Who's this now?
Ma'am, morphologically and functionally close to the parent cell. ma'am.
Okay, so again you're saying this is comparative, okay? But what is differentiation? Are you telling me that lymphocytes, or for that matter your blood cells, erythrocytes do not differentiate, erythroblasts do not differentiate to become red blood cells? Are you now going to talk about differentiation as being functionally and morphologically close to what? A red blood cell is functionally and morphologically close to an erythroblast. But what is it? That is differentiation that is going on. Yes or no, Anis? Yes. So what is differentiation? That's what I want to know. And we use this term all the time. Yeah.
like stem cell.
Oh, so now we're talking about stem cells, huh? But, sorry.
The from the stem cell it gets specialization.
So it is specialization.
Tissue organization and organ towards organ formation.
If you haven't thought about it before, differentiation is this. Whenever you see Asian, it means that we are talking about a process. Okay? Coagulation. Yes? We have the term or not? So, it has to be a process. And this is the process of acquiring the features and functions of maturity by cells or tissues. So, you may have something that gets differentiated and something that is fully differentiated. Okay? And the process by which this particular cell goes through the different stages before it becomes fully mature, that is the process of differentiation. Yeah, now do you understand what that is all about? Excellent. Okay, so if that's the case, now we know what this is all about. When something is completely lacks differentiation, we refer to this as anaplasia. Okay? That means it has no characteristics at all. So when I look at it, I do not know what this particular group of cells is all about. Okay? So it is completely lacking features of any kind. So I don't know where it is going to end up. Now you can have anaplasia that is either monomorphic or it is pleomorphic. Okay, now you see pleomorphic over there, and pleomorphism is what people use this term very loosely all the time. There is mild pleomorphism. No, there is no such thing as mild and moderate pleomorphism. I see it being used all the time. Something that is pleomorphic is markedly varying in size and shape of the cytoplasm and the nuclei. That is what is pleomorphic. So when something is so varying in size and shape, and when you look at it, unless now you go to actually do some kind of immunohistochemistry that tells you what the lineage is. But when you look at it, it is completely lacking features of differentiation. Then you go to find out, is it showing smooth muscle and markers, and we call it a pleomorphic sarcoma or liposarcoma or whatever else. But that needs a lot of very in-depth study by ancillary techniques. On the other hand, you have something like this on the left-hand side, okay? And it could be almost anything. And it's very monomorphic. You can see that they're all small cells. Now that is also anaplasia because it is complete lack of differentiation. And in this case, this is, what is this now? This is a small cell carcinoma. It could be a small cell carcinoma. This one is obviously a small cell carcinoma, but something like a Ewing's tumor. All right, it's Ewing's. We've given it a name. We know that it will express these characters. Before we had immunohistochemistry, we knew that it occurred in the bone and it occurred in the soft tissues. And we gave it a name because it was not a lymphoma, it was not a small cell carcinoma, etc. But it is an undifferentiated tumor. So do you understand what you can use these terms, undifferentiated tumor, or you can use the term anaplasia. Today, by and large, the word anaplasia is not used for monomorphic tumors. It is used essentially for highly pleomorphic tumors with marked variation in size and shape of the cytoplasm. Anybody there can quickly give me one example of an anaplastic tumor?
ALCL.
ALCL. All right. Okay. Anybody else? Now ALCL is a lymphoma, and yes, it was called that anaplastic, but because it had marked variation.
Anaplastic carcinoma of thyroid cancer.
Very good. So you get an anaplastic carcinoma of the thyroid. You'd never know that it was a thyroid carcinoma. It looks like a sarcoma, but yes, we know that it arises in the thyroid, and we know the way that it loses its differentiation. It starts from either a follicular or a papillary carcinoma, which show you good differentiation, moves through a poorly differentiated carcinoma, and finally it becomes totally anaplastic. Excellent. So now I think we can go to the next thing, and this is very obvious, right? What is a cancer? It's a malignant neoplasm. I don't need to ask you that. But here we are at this, and I'm an oncopathologist, and all of you have seen a lot of malignant tumors. How do we know that a tumor is malignant? Come on, Anis.
For that, then we come to the hallmarks of.
Sorry, how do we know that a tumor is malignant?
We look for just like.
Look for the features. So, what features are you looking for, Anis?
We'll be looking for whether there's any invasion or not.
Whether there is invasion or not. Right? Very good. Right. What about in cytology? Can you tell whether there is invasion in cytology, Anis?
No, ma'am. No.
No, ma'am.
Then
What do we look for?
Then we look for the nuclear pleomorphism. Then
Nuclear pleomorphism, all right. So in other words, you're saying that there are cytological features that tell you that something is malignant.
Yes, ma'am.
Do you think that that's a
yes, ma'am.
yes? Okay. Sikandar, you agree?
Ma'am, yes, cytological features can help.
Cytological features can help, but how do we know for certain that something is a malignant neoplasm?
Ma'am,
Who else would like to attempt this? Ashita?
Pleomorphism, ma'am.
Pleomorphism. So you are looking for cytological features. So it has to look like it is a malignant neoplasm. All right, Aishwarya?
Gross also we can identify. It's not well.
Gross you can identify it. Okay. All right.
Clinical history also, like rapid growth.
Clinical history. All right. Ujjwal?
Ma'am, we can look for pleomorphism, then NC.
That's what you said. All right. Good page. Somebody else said that. Good page.
Cytology, morphology, and how the
Atypical mitosis.
tumor behaves.
Atypical mitosis. That's right. Okay. You know, sorry, folks, malignant neoplasm is not by how it looks, it is how it behaves. Please remember that. Okay? A tumor may look completely innocuous, and still we call it malignant. Okay? Can anybody give me an example of that? So, malignancy is judged by behavior, not by appearance alone. And Anis was right. One of those behaviors is invasion. The other one is metastasis. Okay? So you might ask me, how do I know by looking at this that it's going to invade or it is going to metastasize? You cannot know. You have learned this by other people's experience. Okay? So I did not go into pathology and discover everything for myself to say that this thing that looks innocuous, like a papillary carcinoma of the thyroid, okay? Show me what are the features in a papillary thyroid carcinoma that actually look malignant. Nothing. They don't have mitoses. Yeah? And let me tell you, there are some even more malignant tumors that don't have mitoses. On the other hand, I've shown you two things over here. The ugliest malignant looking tissues is trophoblast. You know that. Okay? And it's full of, giant cells and, pleomorphism and multinucleated cells with very dark and hyperchromatic nuclei, all sorts of things. And yet, that is normal. It is not malignant. So, malignancy is cancer is as cancer does. It has had to have demonstrated in the past maybe, and people have noted this, that this looks, it doesn't have all the features of cancer. Take neuroendocrine tumors. All right, neuroendocrine tumors, carcinoid tumors, do they look malignant? They don't have high nuclear cytoplasmic ratio, whatever it is that you teach your second MBBS students, because many of you probably in your institutions are given the task of taking some lectures with your second MBBS students, and you tell them, you draw this chart and you say all the features, they are well circumscribed, they are encapsulated, they are this, they are that. All of that is very relevant. I know that this is a malignant tumor because it has either demonstrated invasion or metastasis, and even in those cases, a mole is invasive and it is not malignant. It might even metastasize to the lung. You know that there are hydatidiform moles that go to the lung, but they are not malignant. Okay, it's just the way that this normal tissues or tissues that are benign, this is the way that they behave. So we need to know that what is the behavior, that A, it is a tumor, B, that it is a malignant tumor because it has demonstrated invasion and metastasis. Okay, so don't go only by appearance. Now this tells you something else. Okay, and we are all pathologists. So how do we make diagnoses of cancer? The answer is simply this, that we are standing on the shoulders of giants, the people who actually studied all this and have put it into the textbooks, they've put it into articles, papers, talked about it, and that is how science progresses. We know what we believed at one time, and now over the years we are finding out that something that we thought might be, we used to think carcinoid tumors were particularly those that occurred in the appendix. We believed they were absolutely benign. Maybe they still are, unless they get to they grow to a particular size and they breach the serosa. Then nobody can guarantee that carcinoid tumor, it looks no different from a tumor that is unlikely to metastasize, but it has shown its capacity to invade, to enter into structures where it should not be, and then you have no choice but to recognize that it is a malignant tumor. What you call it, how you, what kind of differentiation, and how you grade it is a completely different matter. Any questions in the chat box about this, please? Or any of you have got any questions about this? Okay, so it's about behavior, and we know about behavior because we were told by people that this is so, and we have observed it, okay, for ourselves. So that is about cancer. Okay, what is it? Now let us come to some other words which we have a lot of problem with. Dysplasia and in situ carcinoma. And I have shown you some pictures here on the right. Okay. Now let's ask somebody. Sumita, would you like to tell me which picture is dysplasia, which picture is carcinoma in situ? You can just tell me there are three pictures. There's one on top, one on the bottom, that's left and right.
The one on the bottom right is carcinoma, in situ carcinoma.
All right. Of what? Of squamous epithelium, right?
Yes, ma'am. Squamous epithelium.
Okay. Then tell me anything. And what do you want to say about the top?
It looks like
line. There's a little line that is drawn there. Okay. You see the line?
Yes, ma'am.
Very good. I think I better get a pointer that has some. All right. Here. All right. You see the line?
Yes, ma'am.
So what do you think is left of the line and what is right of the line?
On right of the line there is maturation.
Okay. And left of the line? It is not. Okay.
Yes, ma'am.
So there's less, according to you, maturation. All right. And what about this on the left-hand side down here, Sumita?
This one,
Difficult, right?
Yes,
we know that there is dysplasia. Yes?
yes, ma'am.
Now, is somebody going to call this high-grade dysplasia or carcinoma in situ? But you see these. Now, so Sumita, you were able to look at this. So can you define for me what is dysplasia?
Abnormal cellular morphology, which has not invaded the basement membrane, is dysplasia.
So what did you say? Abnormal cellular morphology and not invaded its
Basement membrane.
membrane. So does it apply only to stratified epithelia, or can you have dysplasia in the endometrium? Can you have dysplasia in the colon? We say, adenoma with mild, moderate, and severe dysplasia.
Loss of polarity.
Loss of polarity. Okay, what is this loss of polarity? Can you tell me? See, I've got pictures here. So for number one, what is dysplasia? Right? Can anybody define dysplasia for me? Sumita has tried. Somebody else wants to try?
Disordered
Wants to
growth.
try?
Arrangement.
Tell me, Gurtej, you want to try?
Disordered
I heard a making noise.
Altered sleep.
No, somebody I can't find out who it is. Who is it, Tejas?
Ordered arrangement.
Well, let's not waste much time. We all need to know how to define things, okay? And we can't put everything into this mix. This is what dysplasia actually is, okay? I wouldn't look here and there for a definition. It's so obvious. You don't get dysplasia in lymphoid tissues. You don't get dysplasia in mesenchymal tissues. You get dysplasia in epithelia. Okay, and it doesn't matter whether this is glandular or it is stratified. So what is dysplasia? And if you have understood once again the definition of neoplasia, do you or do you not believe that dysplasia is neoplastic? Is it neoplastic or not? Gurtej, is dysplasia neoplastic? No, ma'am. All right, very good. Tejas, is dysplasia neoplastic? Tejas has disappeared. Okay. He's tired. He just went for an interview. Yes, Ujjwal, is dysplasia neoplastic?
No, ma'am.
No, ma'am. All right. I can see Ashrita. Ashrita, is dysplasia neoplastic?
No, ma'am.
No, ma'am. Sumita?
No, ma'am.
No, ma'am. What about Aishwarya?
No, ma'am.
No, ma'am. Sikandar?
No, ma'am.
No. Anis?
No, ma'am.
No, ma'am. So, is there a difference then, my dear friends, between CIN, meaning in situ neoplasia, and dysplasia? Are they different things, Sikandar?
Yes, ma'am.
They are. So, in situ neoplasia is different from dysplasia. Yes?
Yes, ma'am.
Oh, really? What about you, Anis?
Yes, ma'am. It is different.
It is different. So, will you explain to me the difference
Ma'am,
between in situ neoplasia and dysplasia?
yes, ma'am.
CIN 1, 2, 3, chalo. And dysplasia. And dysplasia mild, moderate, and severe. Is it different?
They like get connected, but the thing is, in carcinoma in situ, there is full
I am not
thickness.
talking about carcinoma in situ. I am talking about CIN 1, 2, and 3, and dysplasia mild, moderate, severe, stroke, carcinoma in situ. Because we know that. Yeah? Dysplasia severe dysplasia is also carcinoma in situ. So,
Yes, ma'am.
yes, so now you told me that, Anis, a little while ago, that dysplasia is not neoplasia. But do you think that CIN 1 means low grade dysplasia, CIN 2 is moderate dysplasia, and CIN 3 is carcinoma in situ or severe dysplasia? Do you believe that or you don't?
I believe that, ma'am.
So then why did you say that dysplasia is not neoplasia? It's the same thing, except that it is
It's not breaching,
it is not
invading.
invasive, okay? But it is neoplastic. And if you remember, what is the definition of neoplasia? What is the definition? He may not be there. Come on, Ujjwal. What was the definition of neoplasia? You wrote it down. I know that. What is it?
Ma'am,
You haven't written it down. I know that Ashweta has written it down. Yes, Ashweta? So now, tell me, read loudly, what is the definition of neoplasia?
An abnormal mass of tissue, the growth of which exceeds and is uncontrolled, and that of normal
Uncontrolled. Did I say that that was the definition of neoplasia?
Uncoordinated.
What was our definition of neoplasia, Ashweta?
An abnormal, often clonal, cellular proliferation that exhibits uncoordinated growth and disorderly differentiation
Yes.
in a multicellular organism.
So do you think that it fits this or it doesn't fit it?
It fits, ma'am.
It fits. Exactly, it fits. So it is progressive lack of differentiation in epithelia, and what it says is that this is not invasive. That's what it is. You see the grades of architectural disorganization, grades of atypical cytomorphology, and graded abnormalities of differentiation. So dysplasia means, and this can happen in glandular epithelia, in stratified epithelia, but there is no invasion. In glandular epithelia, an example is an adenoma. An adenoma, all adenomas have dysplasia. Okay? It's either mild or moderate or severe. So, that is what is dysplasia. And okay, we'll come in the next thing to see what it is. Carcinoma in situ is complete lack of differentiation without invasion. All right, all dysplasia does not show invasion. Carcinoma in situ, in particular, you have to make certain to say that there is no invasion. And all the grades you can see over here in this picture, this happens to be from a larynx. It's not from the cervix. So this is laryngeal dysplasia. This one on the right of that line is showing you mild dysplasia. On the left of the line, you might say moderate dysplasia. Here, this is high-grade dysplasia and you have problems. Should I call it severe dysplasia or carcinoma in situ? Doesn't make a difference at all because they're more or less the same. And here you have severe, carcinoma in situ, but there is no invasion. Anybody have a problem? Are there any questions in the chat box? People just don't know how to even define dysplasia. Okay? And what is the meaning of disorderly growth? And that's where all this story of, and we said it is graded grades of architectural disorganization. So what do you mean by architectural disorganization? Take squamous epithelium. What do you mean by architectural disorganization? We understand atypical cytomorphology and you can see it. Okay, the cells are larger, there is cytoplasmic, the nuclear cytoplasmic ratio is altered. You also see some abnormal looking nuclei, they show you crinkling, whatever else. Okay, but what do you mean by grades of architectural disorganization? Anybody wants to answer that question? Yes, Anis?
Ma'am, especially if you take it as squamous epithelium, ma'am, the cells are arranged in an orderly manner. They are in layers, ma'am. Actually, see here.
I know. This is what somebody mentioned, and I think it was Ashrita. She said lack of clarity. Okay.
Yes, you know.
Yes.
So there is haphazard arranged.
Polarity. Now see this picture down here. It's there in all. Okay. But you see it very clearly on this left-hand side picture, okay? All the cells in a normal epithelium should be, the basal layer should be perpendicular to the basement membrane, yes? And above that, they should flatten, all the cells should flatten and then they become parallel to the basement membrane. That is normal polarity because polar means in respect of something. So, in respect of the basement membrane, this is how we find normal architectural organization. Now, we said that neoplasia, in one way or the other, and the more severe it is, the more likely it is to be malignant, is you get severe disorganization, architectural disorganization, and now you can see it. Do you think all of these are placed nicely parallelly? Some are, placed at angles, etc., etc., and of course you see atypical cytomorphology. So, this can not be called normal, and this is what is called lack of polarity. Has anybody got any questions on that, please? And if it's in the chat box, please let me know.
Yes, ma'am. This one is poorly differentiated and de-differentiation similar.
Poorly differentiation and de-differentiation is, both of them have got poor differentiation. But de-differentiation assumes that once upon a time that tumor had better differentiation, okay? And now that differentiation is lost. It is now losing its differentiation. So say I had pleomorphic adenoma and I knew it looks very benign and everything else, then it de-differentiates to a carcinoma. Or I have a nice, well-differentiated chondroid tumor, which you can see the hyaline cartilage and everything, and then suddenly it goes wild. Now you might ask, why? Or how does it de-differentiate? Now I don't think that a fully differentiated cell is able to go back. So it is a tumor. There are stem cells in that tumor, and those stem cells are differentiating beautifully, all right, into the fully mature form. And for all practical purposes, that was benign. And then what happens, those stem cells, something happens to them. Either they acquire a mutation or there is a change in the environment in which those tumors are growing. And you know that that can happen if, for instance, we have a better or less well-differentiated tumor that is given radiation therapy. Okay? And that can convert a nice, well-differentiated tumor when it recurs into a very high-grade tumor. So the stem cells there have had something, that a switch in their genome that makes them less susceptible to the differentiating influences that are coming to that tumor. Is that all right? Has somebody understood that? We can discuss it again if.
Yes, ma'am. So, as an extension to that, is dedifferentiated same as undifferentiated? That's another question.
Yes, it is. No, then it becomes undifferentiated, of course. But we know that it was well differentiated, and therefore we call it dedifferentiated. If you never knew that there was a well differentiated tumor, then you call it undifferentiated. It's as simple as that. Okay.
All right. And
so there are some that come that are undifferentiated de novo, and we know those tumors. Some of them we talked about, and you know that we call the anaplastic thyroid carcinomas. We gave that example. Yes, it starts out as being well differentiated, follicular or papillary, goes through poorly differentiated, and then it becomes totally undifferentiated and anaplastic. And when you see this patient at the last stage, you may not be able to see the original well-differentiated tumor from which it arose. All right?
One more question. What is the difference between high-grade dysplasia and carcinoma in situ?
There is none. It's the same thing. Okay?
That's all, ma'am.
Yeah. All right. Very good. So now this is what this is. Okay? And now we have terminology. And that's what I was asking you. The terminology for dysplasia and carcinoma in situ could be in situ neoplasia, and you can have cervical in situ neoplasia, you can have vulval in situ neoplasia, in which you call it VIN. In the endometrium, you call it EIN, that is endometrial intraepithelial neoplasia. You say, or atypical hypoplasia, some people call it atypical hypoplasia, okay? And then there is this term EIC, which is endometrial in situ carcinoma. That is used for the serous type of intraepithelial neoplasia, whereas EIN is used for the endometrioid. I don't want to sort of split hairs here, because most of you may not even have heard of serous carcinomas of the endometrium. Okay. Then in the breast, you say atypical ductal hypoplasia and you say duct carcinoma in situ. There is absolutely no histological difference between the two. Okay? If you have low-grade DCIS and ADH, it is only the extent. So if you have a larger extent of tumor, you call it low-grade DCIS, otherwise you call it atypical ductal hypoplasia. So you're getting the idea that pathologists are now splitting hair, okay? And so you have DCIS of low, intermediate, high. And I just told you that adenomas in the colon, in the stomach, etc. are graded with low, moderate, and high-grade dysplasia. So now all my 9 students over here, do you agree that dysplasia is neoplasia? Is it? Do you agree or you don't?
Yes.
Yes. So all of you said no, but I'm glad that you have understood this. All right. Now, I'm going to ask, this is now cervix. Okay. So, who has done cytology? Because some of you who have done in the first year have not done cytology. So, Ashweta, have you done cytology?
Yes, ma'am.
You've done?
No.
Which year are you in? 18 months you've done?
14, ma'am. I'm in the 14.
14 months. So did you go through cytology? You
Yes,
see
ma'am.
pap smears? You have?
Yes, ma'am. I have seen.
So maybe you can answer this question. Okay, who's that now? Was it Ashrita or was it Anvesha? Ashrita, yes. All right, tell me. This is CA and this is normal. Okay. This is CIN1, this is CIN2, and this is CIN3. All right. Is the diagnosis of 1, 2, and 3 possible on a pap smear? Yeah. The answer is simply yes or no.
No, ma'am.
No, ma'am. All right. Anvesha?
Ma'am, possible.
Possible. Okay. Aishwarya?
Ma'am, like counterparts can be given, not the exact diagnosis in 1, 2, and
Right, but is the diagnosis of CIN 1, 2, and 3, you'll call it L-SIL and 8-SIL, doesn't matter. So let me say L-SIL. Is the diagnosis of L-SIL possible by pap smear?
Yes, ma'am.
Yes, it is. So in other words, you're telling me that CIN1 can be made, right? The diagnosis?
Yes, ma'am.
Sumita, is it possible?
Yes, ma'am.
All right, Tejas?
Yes, ma'am.
Oh, okay. Ujjwal?
Yes, ma'am.
Excellent. So all of you said, and the answer is absolutely right. As the chat box said, it is yes. Yeah, because everybody will make the diagnosis, right? But now I want to know, you see the difference over here? You don't know who, all of you will tell me what is CIN1 and how do you differentiate it from CIN2 and from CIN3? Will somebody tell me on histology? And I've got the pictures for you here. How do you differentiate that?
The extent of dysplasia.
This extent of dysplasia, what do you mean by that, Ashrita?
The full thickness, or it is
Full thickness, okay. That is CIN3, right?
yes, ma'am.
Excellent. Then,
In the
that is
CIN1
full
it will be
thickness. So that means
less
the
than
whole
1/3.
epithelium. Then, so what about CIN2? Come on, Ashrita.
Ma'am, if it is less than 1/3 of the thickness, we call like SIN1.
Sin1. So here, less than 1/3, it is Sin1 in this big picture. And then
If it is
2/3,
more than one-
it is, which you see over here, it is CIN2,
Sin2.
right? Excellent. And this. So now, Ashrita, or any one of you, you're going to tell me, how do we make a diagnosis on pap smear? We take a smear, right? So we take one of these swab sticks, or we take a spatula, and then we take the superficial layers, right?
Yes, ma'am.
Yes, and we smear them, correct?
Yeah, ma'am.
But I heard, Ashrita, just now, you telling me that the abnormality is in the lower 1/3 in CIN1, it is 2/3 in CIN2, and it is full thickness in CIN3. So I will be able to make a diagnosis of CIN3, no? Because the top layers are come out on my smear. So how do I make the diagnosis of CIN1 and 2? What do? I scrape like that? No, I don't. So come on, Ashrita, how do I do it? Because you all answered yes.
In PAP, we can give like L-SIL and H-SIL depending upon the
I
other
don't
features.
care whether you call it L-SIL or H-SIL or you call it CIN1, 2, which CIN1, which is L-SIL and the other two are. I want to know if the abnormality is in the lower 1/3 or lower 2/3. How do I make the diagnosis on a cytology smear? Because I'm just taking the superficial cells. Yes or no?
Yes, ma'am.
Oh, very good. So, Anvesha, everybody answered yes, yes. depletion in epithelium. Yes? So what is the meaning of progressive lack Yes, Harish.
We said the mutated P53.
Yes, I know it is mutated P53, but I don't think I have an antibody to mutated P53. I just have an antibody to P53 protein.
Yes, ma'am.
So why am I seeing
Overexpression.
overexpression? Do you think that this is just overexpression?
No.
No. Okay. So here is another question, and I'll ask you.
We say
next
it is low